Well, good morning, everyone, and welcome to yet again another episode of Driving with Dr. Kidney. My name is Dr. Mark Russo. I'm a nephrologist practicing here in Naples, Florida, and today our guest is Asa House. Asa is one of our dietitians that are associated with us and U.S. Renal Care. Good morning, Asa.
Good morning.
Why don't we start off with you telling us a little bit about yourself, a little bit about your background, how you got involved with nephrology and dialysis patients.
Sure. So I've been a dietitian for quite a while, about 20 some years now, and most of my career has actually been spent in kidney care. So I've been a dialysis dietitian for a long time, and it's such a great place for a dietitian to be because there's so much for us to do. There's like an ongoing thing with our patients, month to month, the lab work, and a lot of how you feel and how you do on dialysis is really related to what you're eating. So I'm super excited to be part of that. And this position that I have now has led me into interacting with our chronic kidney patients as well.
Right.
There's a lot of resources, I feel like, for the dialysis patients, PD and hemodialysis, and maybe not so much for the chronic kidney patients. So I've been really excited to spend some time with them and talk about treatment options and things like that that's coming up. They're moving closer to dialysis and just letting them know what the options are and kind of making their individual plan.
I see. Excellent. So right now, as you pointed out, a lot of the things that we're doing today is focused on prevention. And that's why you're getting involved with the individuals prior to being on dialysis and hoping that we slow down the progression. And one of the main things that we ask of patients to do is be independent and involved in their own care. And that to that question, or one of the questions that comes up a lot of times is, what can I do as a patient before I'm on dialysis to help prevent it? And this is one of the topics that's always argumentative is, should I be reducing the protein in my diet? Do I really need to watch my potassium? Or when is it time that I have to start watching my phosphorus? So maybe if we could start off, what is your view on protein restriction? Because there's always that balance between restricting protein and worrying about nutritional balance or nutritional status versus the protein being a little bit too rough on the kidneys as it's filtering through, as that protein is moving through the filtering units of the kidney.
Of course, it's a balance, and it's highly individual. So I'm really glad that I get to spend one-on-one time with these patients. Oh, was that you, Mike?
I think it was.
So we can look at what their diet is now and how it compares to their lab work. So that's really the driving force. Protein, it's a really delicate balance because you don't want to make anybody malnourished.
We're discussing protein levels and a balance of protein intake versus protein restriction in the patient before they're on dialysis. So take it away, Asa.
Yes. So there is a delicate balance between how much you should eat and how much you need, so you don't get a scenario where somebody becomes malnourished and their albumin might start dropping. And it's just the literature is saying that it's a good idea to restrict the protein, but you've got to find that balance. So the studies that I read, the protein that comes from plants doesn't stress the kidneys as much as something that will come from animal products, so the vegetarian diet. But I'm really careful with throwing that out to the patients because that could really create something tricky. It's really hard to follow a vegetarian diet. So sometimes I just suggest maybe a meal a week, 2 meals a week, just to offset that. But we're looking at portion sizes. I'm teaching grams of protein, what that would look like on a plate. And it's all very individual. I think a lot of people don't really have the issue with eating too much protein, honestly. They might be the opposite.
Okay. So, and do you get some pushback from any of the patients? Do they give you a hard time and they say, no, I can't do this. I'm used to eating a steak, a hamburger, etc. Is it hard for them to do? Do you find that they have a difficult time following that type of a diet when they're watching these things?
It could be really difficult. I think the kidney diet is one of the hardest ones for our patient, and that's why it's so helpful that there dietitians like us available for them to kind of sort it out and make that individual plan. Some people ended up where they are because they didn't do what they were told to do, and it's hard to change. Change is really hard. So instead of changing the whole thing, some people are really good with just starting new, tell me what to do. Other people need a little stepwise approach, maybe not taking something away, but we're adding something to the meal and eventually just replacing things.
So typically, do you see a difference or a major difference in patients or individuals that are on dialysis versus prior to being on dialysis? Is it the same diet? Because sometimes the patients will come in, excuse me, and they'll say, hey, I was on the internet and I have to follow a kidney diet or a renal diet. Well, what is your typical response to them? And if they're prior to being on dialysis versus on dialysis?
So just before dialysis is probably the most particular you are with your diet. It's very tedious and it's hard to keep that up. And once you start dialysis, that's one good thing with starting dialysis. Now you can liberate that a little bit because now you get help cleaning those toxins out. We're still watching like the potassium and the phosphorus if you're on hemo. But yeah, it's a little liberating. And the protein, now we're going to throw the stakes at you. We want you to eat a lot of protein now because that's going to kind of drop when you start this treatment.
Correct, because now they're in a hypercatabolic state and they're always breaking down more than they're making, and that's what we want to try to keep up with it. And of course, the filter is removing things that we don't. It's removing things that we want them to the filter to remove, and of course, in addition, it's removing things that we don't want it to remove. So very good. You mentioned two electrolytes. You mentioned phosphorus and potassium. So briefly, potassium, we worry about it getting too high because it can lead to a cardiac rhythm problem, and the patient may develop some ventricular tachycardia or ventricular fibrillation, and that's one of the reasons why we want them to limit the potassium. But some patients can get away with that early on. So what are some of the foods or things that you actually tell the patient that they've got to be careful about?
So it's tricky because this is all the good stuff. This is your bananas, this is your potatoes. We live in Florida, and I'm going to tell you, be careful with eating avocados and salsa. Yeah. So these are the foods that are high in potassium. Anything made with tomatoes, any orange juices, potatoes, French fries, anything from the potatoes. There's a way to dialyze your potatoes. You soak them and double boil them. You leach some of that potassium out. Same thing with beans and things like that would have a lot of potassium. You can leak that out in the water, but still, it's the monthly lab work that's dictating how strict we have to be with these things.
I see. So some patients, that are seeing a slightly high potassium are going to be at increased risk of these problems, and then you'll sit with them and talk about, and you'll dig through what their particular diet is, and you'll help identify the foods that they might be overeating that they can reduce or cut back on. And that's, I know I tell our patients that just because you're on a potassium restricted diet, it doesn't mean you have to stop eating these foods, but maybe you have to now start reducing a significant reduction in the intake of those foods.
For sure. That's why this conversation is so important. We want to know if there's something sticking out. Obviously, please don't overdo that, and then we have to get a little bit more into it.
Right.
Yeah.
Okay. So and as you pointed out, if everything is sort of individualized, and not everybody's in the same situation. Some are always at increased risk, and unfortunately, sometimes we have to put patients on an additional medication on the days that they're not on dialysis, or prior to being on dialysis, they may need to be on a medication to help reduce or keep that to help keep that potassium level down. And the other electrolyte that we talked about was phosphorus. And very briefly, a high phosphorus occurs because your kidneys cannot get rid of that phosphorus because they're rather weak, and the charge on the molecule is negatively charged, and the kidney has a difficult time getting rid of negatively charged particles. So what we do is and why do we worry about that high phosphorus? Well, high phosphorus combined with calcium and make a stone, and what we're doing is we're making stones in the blood vessels, and that leads to worsening hardening of the arteries or atherosclerosis. So when we talk about limiting phosphorus foods, it's not something that you're going to feel and be problematic initially or overnight or within the next couple of days or weeks, but this is something that's accumulative, and that's why we ask our patients to reduce that phosphorus intake. And if you could tell us a little bit about how you work on the phosphorus limitation, et cetera.
Sure. So that's not part of that food label. It's hard to know just looking at food what has phosphorus in it. You kind of got to know what they are. Most of the times it's an additive that we add to foods to keep longer. It could be anything that's processed. Could be even in drinks that you have to look at the labels on the drink. Phosphates, phosphoric, anything on that ingredients label would indicate that it has phosphorus in it. So it's just a matter of constantly repeating. So you learn eventually what the foods are that you should be careful with.
And if we and many of the things that we do, or the foods that we eat, we tell them to if we're aiming to reduce the phosphorus intake in the diets. Sometimes we have to ask them to take a pill, and that's what we call the binders. And the binders could be different. There's multiple binders that we have. Some people will be intolerable to some of them. They may get some GI upset, etc. But we ask them to take those pills. And if you can tell us a little bit about them, you don't have to mention their names of them, but maybe how we take them and what it is that you usually recommend.
For sure. So adding in medication is always tricky because most of our patients have a lot of medications, but this is a simple thing that you can do to reduce that phosphorus, and you can enjoy a little bit more of a phosphorus intake by doing that. So there's something that you take with your meal. It's not going to work sitting on your kitchen table or your counter. It's actually have to be there in your stomach with the food when you're eating. So ideally you would start eating your meal, a couple of bites, you take a binder, and then you finish your meal so that it comes down in the stomach with the food and it binds that phosphorus and brings it out of your body. So that's the idea of the phosphorus binder.
Excellent. So something that your kidney was capable of getting rid of, and now your kidney is incapable of doing it. Now we have to take advantage of your stool or your GI tract and ask the GI tract to get rid of that phosphorus, so you get less potential hardening of the arteries. All right, so we covered quite a bit today. And then the final thing that we want to talk about is fluid intake. Many of the patients, before they're on dialysis, they're still urinating. And I tell people all the time, well, your kidneys make urine and your kidneys make water. And one of the last things or final things to go, or for your kidneys to lose, is the ability to get rid of water. And so when a patient starts dialysis, as time goes on, we rely more and more on that filter to get rid of the fluid. And it becomes very challenging when a patient has a hard time limiting the amount of fluid that take in. So what are some of the tricks that you talk about, and maybe tell us a little bit why it's important to limit the fluid intake once you're on dialysis?
So this is probably the hardest part of this diet for our patients. I would have a hard time limiting my fluids, and we're talking 32 ounces. That could be my morning drink, and that will be it for that day. So we have to figure out how to help them drink less. You gotta drink less. So we use things like ice chips or frozen grapes. Have you ever tried frozen grapes? They're very amazing. Maybe chewing on mint gum, mint tablets or something like that, just to help you drink less. And this portion out. Sometimes measuring in measuring cups. After a while, you learn what a cup would look like, and that will be the limit maybe for that meal.
I see. Very good. All right. So we've gone over quite a few things here today. We've talked a little bit about the limitation of phosphorus, potassium, fluids, and also protein. And those are the things in summary of what it is that we're going to be paying attention to. And we also ask that the individual's family members get involved in such an issue to actually help out with the diet. And actually, some patients have told me that their families eat a lot healthier and much better once they're on a kidney diet or a renal diet. One of the electrolytes or things that we did not mention that probably is universal, that's extremely important to limit, and that's sodium intake. Mm-hmm. Sodium intake must be restricted because water follows the sodium, and that we found out over time that it does or it can contribute to worsening high blood pressure. So, and as Asa pointed out earlier, some of the preservatives in the foods that have phosphorus in it will also have sodium. And that sodium is important to limit So this way you now maintain a situation of reduced blood pressure as well as reducing the amount of fluid that the patient is holding on to. Okay. So again, Dr. Mark Russo, driving with Dr. Kidney, and we want to thank Asa for joining us today, and look forward to future conversations with her.
Thanks for having me.